stretch that out to 10 years, patient has an 85 to 90% freedom for reintervention, which I think is pretty remarkable for any valve substitute.
Hey guys, Andrei Pop here. I manage the aortic channel on Murmur MD. We are privileged today to be joined by Dr. Chris Malaisrie from Northwestern Memorial Hospital in Chicago, my hometown here. Dr. Malaisrie is attending cardiac surgeon at Northwestern Medicine. He's a professor in the Division of Cardiac Surgery, and he co-directs the Marfan Clinic, Bicuspid Aortic Valve Clinic, and Thoracic Aortic Surgery Program. Dr. Malaisrie, great honor to have you on this program.
Great to be here with you, Andrei.
You know, the reason I wanted to talk with you, I have a lot of interest in lifetime management of aortic stenosis, and I know you have been doing something which a few years ago was very unusual, and I don't think there are many places around the country that do it to the same degree and with the same results that you do, which is the Ross procedure. Maybe we can start talking a little bit about the Ross procedure, and then we can talk about some other aspects of lifetime management. You've published a lot on a lot of areas that are interesting to lifetime management, and I think our audience would be very interested to hear about that.
Well, great. Yeah, can't wait to get started.
So, the Ross, you know, it was something that I learned about in fellowship. I never seen it in real life, and then I started hearing that you're doing it. How many cases have you guys done so far?
Yeah, we've done over 100 Ross cases here, and this is after the restart. Ross procedure had gained popularity in the 1990s and then fell by the wayside the early 2000s. I think it's because a little bit higher perioperative risks, and some of the cases were coming back for reoperation. But there's been a resurgence of the Ross procedure, mainly because we're able to do it in such a safe fashion. And the surgical techniques and the perioperative managements have led to increased durability for the Ross procedure.
And, you know, the classic teaching, I guess, was that when the Ross fails, it fails by aortic insufficiency, dilation of the aortic autograft. Is that what you're still seeing, or have the surgical techniques changed to the point where that is a lot more rare today?
Yeah, and that's the main failure mode for the autograft, which is the patient's native pulmonary valve and root, is that over time that the autograft can dilate. Dilatation leads to stretching of the aortic valve. You can get central jet, and these can lead to recurrent severe aortic regurgitation. And we can counteract that by a couple ways. The first way is to stabilize the aortic, the autograft that goes in the aortic position. So we do a deep LVOT implantation that stabilizes the aortic annulus, and on the distal end we will do a Dacron graft sewn directly to the sinotubular junction of the autograft, so that'll stabilize the top side. And for the sinuses themselves, we wrap it with the patient's autologous aortic root, which we don't have to resect. We can buttress the root. Some surgeons will buttress it with a Dacron graft. So the autograft is well protected, and that keeps the autograft from dilating over time. There's some medical things that people should know about as well. Because the pulmonary valve has lived in the pulmonary circulation with low blood pressures, we move it over to the aortic position, so it's now seeing systemic pressures. The autograft will remodel. We just want it to remodel favorably. So that's under low blood pressure conditions. We want the blood pressures to be pretty low. So I'll send patients home with a Bluetooth blood pressure cuff. I want the patients to take the blood pressure twice a day and send it to our clinic. We can, on the fly, adjust blood pressure medications. We want the systolic blood pressures to run about the 115 millimeters of mercury. After about 6 months, the autograft is stabilized, the wall is thickened up. we don't need to do that strict monitoring after that.
So you're almost doing like I don't know if this applies, but almost like a Florida sleeve. Basically, you're encasing the autograft inside a Dacron graft or the patient's native root.
Right, that's one technique that some surgeons employ. I don't use that technique. It's also called the jacketed Ross, protected Ross. So surgeons will take a Dacron graft, usually a Valsalva type graft with preformed sinuses, and put the autograft completely within it. So yeah, it looks like a valve-sparing aortic root replacement.
Okay. And do you still see failure with this to the same degree, or the failure rate is significantly decreased with these techniques?
Yeah, failure rate has been pretty low. It's linear, but we estimate the risk of reoperation for either the autograft or the homograft on the pulmonary side to be about 1 to 1.5% per year. So if you stretch that out to 10 years, patient has an 85 to 90% freedom for reintervention, which I think is pretty remarkable for any valve substitute.
And when they fail, I think one of the big concerns we have on the TAVR side is that obviously when homografts fail, when Rosses fail, even when freestyles fail, they fail by aortic insufficiency, everything dilates, and then it's kind of difficult to do a TAVR safely. And you've obviously published on homograft failure, and I still don't know where you found 41 homografts that have failed. Most people are lucky to have seen 5 in their career, I think. But is this is the fact that you're stabilizing the LVOT make TAVR easier, or do we wait for the Jena valve to come around to deal with failures in this case, or what's the scoop?
Yeah, I think for the failing autograft, there's going to be multiple options for the patient. Actually, a failing autograft 20 years down the line, I've certainly seen several cases, can be repaired. So we can do a valve-sparing aortic root replacement. Of course, that means repeat open heart surgery. But some of our Ross patients who've gotten the Ross at 20 years and they need a reintervention at 45, 50, they're still good candidates for repeat open heart surgery and to repair the autograft. So that's definitely very feasible. I think when you get into patients who are a bit older than 50s, 60s, and the transcatheter option can be a option. Definitely looking forward to the newer generation TAVI valves, which are dedicated to pure aortic regurgitation. And Andrei, you're a specialist in transcatheter valve implantation. The current valves rely on radial force in order to anchor in the aortic annulus, which is great for patients with aortic stenosis, not so good for patients with aortic regurgitation who don't have any calcium. These newer valves, and I'm glad to get your opinion on this as well, have stabilizing devices that actually anchor into leaflets themselves. So I think we're entering into some clinical trials that will potentially bring these devices from Europe into Asia so they can become available for our patients in the United States.
Yeah, I think that dedicated devices are going to be definitely the way to go. I think when I look at homografts and freestyles, they get so deformed that I don't know how well those devices will perform, but we're about to find out. The one thing that I always quote from your paper is the fact that you're trying to oversize a lot and you're trying to anchor lower than the annular plane. And I think that's important stuff for people to know, and that's why I think your paper on homografts is an important one.
Yeah, and this is where when you know how the surgical implantation happens, then you know how to do the transcatheter procedure, and that's really good insight. I think you're bringing up to the audience. When we implant homografts, so this is not the Ross procedure now. So in homograft implantations, the suture line is below the leaflet insertion of the homograft. So whereas we're trying to aim for a leaflet insertion for the TAVs, for the homografts, you're sort of shooting for the suture line itself, which is typically about 5 millimeters below what you see the suture line. So that's your target point, and we've had some success with that. Homografts, I think, do very well with transcatheter valve implantation. The reoperation for homografts are risky. The homografts are very calcified and can be tricky to extract.
Yeah, and I think that, my surgeon here describes them as, cutting into shoe leather. That's how nasty they are. So I think a lot of people get nervous about oversizing valves in homografts, and I think, again, in your paper you make that clear that, significant oversizing is necessary, and that's certainly what we practice.
Yeah, and just to make it clear to the audience, what happens to an aortic homograft in the aortic position is not what happens to an autograft in the aortic position. 20 or 30 years down the line after a Ross procedure, the autograft is remarkably free of calcium because it's the patient's own aorta, and it's the patient's own pulmonary valve and pulmonary root. So this is not the problem we're going to see with failing autografts in the Ross procedure.
Yeah, so I think that's definitely an important point. Again, I think most people in practice are lucky to see one or two Rosses maybe in their career. Maybe with you doing such a great job with them, we're still not going to see too many. But the question that I have for you is, how many places around the country do you think have a program that's as active as you and get the results that you are getting?
It's tough to estimate because a lot of good surgeons don't report their results. I think it's fair to say there may be about 10 to 20 centers that do as much as we do. So we do about 30 Rosses per year. And I think the case volumes will go up. We do see that in the STS database, that Ross procedure volumes are going up year over year over the past 5 years. Actually, patients under 50 years old who need valve disease, about 7 or 8% of them now are getting a Ross procedure. So it's nice to have that option for our younger patients. Patients aren't relegated to mechanical versus biologic valve. The third option, in my mind, which should be the first option for less than 50-year-old patients with aortic stenosis, can be the Ross procedure.
Yeah, so I think that's clearly the patient population that we would think about. I think traditionally we thought about women of reproductive potential for the Ross, but I remember you telling me at some point that it's almost 50-50 in your population, male versus females, right?
Yeah, that's right. Yeah, and another good point with females, women, or anyone who is smaller, that the Ross procedure has such good hemodynamics that a small aortic root actually does not become a problem with a Ross. We don't see gradients. We're actually, in fact, doing a study over 4 sites across the United States. We're looking specifically at this question, and I think we're going to be pretty happy with our results, that patients with what we consider small aortic roots are not disadvantaged by the Ross procedure. Actually, Ross procedure can be a good solution for patients with small aortic roots.
So I think that's great, and I think that's kind of the claim to fame for stentless valves in general was low gradients, and the Ross would make sense that it would have very small gradients. And thank you for pointing out the differences in kind of calcification, because that's something that I never thought about of a Ross versus a homograft. But maybe changing tack a little bit, you mentioned small aortic roots, and I think the other procedure that's growing around the country is aortic root enlargement and potentially aortic root replacement for patients with aortic valve disease. The classic story that I always heard is that there's probably 10 people who can talk about an aortic root enlargement, and there's only one surgeon who actually does it. So is that growing? Are we going to see a lot more of aortic root enlargement? What are your thoughts about that?
Yeah, I think so. I think there's two reasons that aortic root enlargements are going to grow in the next several years. The first is that patients, as we operate on them earlier, are going to demand better hemodynamics. I think medium gradients in a 70-year-old who's sedentary, they're really not going to notice that. But if you give gradients to someone who is an active athlete, getting their heart rates above 180, doing high strenuous activity, they're going to notice a difference if they have a prosthesis that has even medium gradients, so patient prosthesis mismatch. The second thing, and this is really interesting to me, is the lifetime management of aortic valve disease. So say you got a patient who chooses a biologic valve to begin with in order to avoid Coumadin, which is probably a patient preference for 90% of our patients we see in the United States. But we also have to think about the second valve that they're going to get. So we should be preparing patients after aortic valve replacement for future TAVI aortic valve-in-valve. And the way to do that is to give patients a big enough valve at the index operation so that they can accept a TAVI valve-in-valve, say, 10 years down the line, if that valve does fail.
Yeah, the only challenge or the only caveat I see to that is occasionally I see roots that are, let's say, 27 millimeters, and somebody has successfully shoehorned a 25 millimeter valve in there. And whenever you put a supraannular valve, the coronaries end up necessarily lower because you have the sewing cuff. And then you have coronaries that are 2 or 3 millimeters high. You have 2 millimeters around the valve, and the top of the post touches the sinotubular junction. And then it's great that they had a low gradient from the initial bioprosthesis, but you know that they are committed to redo surgery down the road. So the question is, would that be an indication to enlarge their root to basically facilitate the next TAVR as well?
Yeah, I think so. Coronary obstruction is one of the biggest reasons patients can't get a valve-in-valve. And doing the root enlargement can allow you to seat it well below the coronary ostia and avoid that risk. Another option that surgeons can consider, and this is an area of research for all of us, is not an aortic valve replacement, but a complete aortic root replacement. And as you know, with an aortic root replacement, we completely detach the coronary buttons, and we can implant it pretty much anywhere we want. I shoot for about 10 millimeters above the new aortic valve, so that keeps it well away from the leaflets. And we found under AI modeling that if you do an aortic root replacement, that virtually all those patients will become candidates for future valve-in-valve.
And do you use is there a particular graft you use? I assume you use a sinus of Valsalva. Do you use like the Connect graft from Edwards, or is there a preference there?
Yeah, currently there are a couple options for a pre-made conduit, and the Edwards Connect conduit is one of them. So that's a standard aortic valve made by Edwards that is pre-constructed in a Valsalva graft. So it is off the shelf, since it's resilia tissue that it comes dry stored, so it is ready to use out of the box.
And is there ever an issue about the length of the coronaries, being able to implant them higher up? Because in talking to people, I was told, well, you can't always move the coronaries as high as you want because there's length issues. Is that an issue? Do you ever have to do a bypass, from the root to the coronary, or how do you handle that?
Right, well, we're usually doing an aortic root replacement because there's also concomitant aortic root aneurysm at the minimum aortic dilatation. So even patients with small dilatation, say like 4.5 centimeters, the root is already mobilized upwards and away from the aortic annulus. So with good mobilization, I think most surgeons can get the buttons up higher than they usually would, and that would really help with future valve-in-valve.
I wish everybody was doing things the way you are. I mean, we're still seeing a lot of cases where redo TAVI is not possible. Do you CTA everybody before you do a aortic root surgery for an elective case, obviously?
Well, we do only because almost every case is going through valve clinic, in which case pretty much every patient gets a CT TAVI protocol. And those are very useful, obviously, for TAVI planning, but we're finding it more and more useful for pre-surgical aortic valve replacement. We can tell almost as good with surgical sizing with the preoperative CTA exactly what valve size the patient is going to get. So before the surgery, I'm going to know whether or not the patient is going to require an aortic root enlargement. And this is important because I do my isolated aortic valve replacements through a mini-thoracotomy, and which is a great operation for isolated AVR. I prefer not to do an aortic root enlargement through a minimally invasive keyhole approach, so I know up front whether or not I'm going to have to do that. And some of the AI modeling is able to tell you if you do this patient with a certain size valve with a particular technique that the patient will or will not be a candidate for future valve-in-valve. I think that's some really cool stuff that is available to us now.
And you mentioned the keyhole incision outcomes, same as a full sternotomy. Do we know that, or?
Yeah, it is, and it's been studied pretty well, especially for aortic valve replacement. We call it minimally invasive cardiac surgery, MICS for short. There's two ways to do MICS AVR. One is through a upper hemisternotomy, which is partial sternotomy. The other way is through a right anterior mini-thoracotomy, so in between the ribs, typically between the second and third rib. And the outcomes show that there is no penalty in 30-day mortality. Actually, there's a benefit in renal failure and benefit in less blood loss, so less risk of getting perioperative transfusions. But for me, I think a mini-thoracotomy for isolated aortic valve replacement has the biggest benefit for our patients because I only require 2 weeks of exercise restrictions after a mini-thoracotomy AVR. Patients can go back to their normal activity after surgery after just 2 weeks.
No, that's great. How about the concept of TAVR first? Young person says, you know what, I run marathons, I do whatever. Maybe they're not, maybe they're in their 50s, they're the unicorn that has good anatomy for TAVR, and they say, I really want to get a TAVR and then I can get an explant later. Do you think there's any value to that, or what's your take on that?
Well, I think it's a growing area of interest, and it also depends on what is the second operation. And TAVI inside TAVI is a growing area of study, and it appears that it is going to be a feasible option for patients. Aortic valve replacement for TAVI explant, on the other hand, is not yet perfected, as you know, and the risks are a little bit higher than we thought they would be. Taking out a TAVI valve actually has more risks than taking out a surgical aortic valve replacement. I think it's because of where the valve touches the patient. So the surgical aortic valve replacement, the only thing that's really touching the patient is the annulus on the sewing cuff. Not so for TAVI. The TAVI will be touching the LVOT as well. The self-expanding valves with the supraannular component will be touching part of the aorta. So these things that touch the parts of the patient can also get damaged. I think that's the risk that we run with TAVI explant.
Yeah, and I think the current data we have for TAVI explant is not great. The reasons for that may be debatable, right? I mean, a lot of patients may have endocarditis and whatever. But I think it is the fastest growing cardiothoracic surgery procedure right now. You guys are doing a lot of it, and it's interesting. I was looking at the 5-year data from the EVOLUTE trial, and the valves that failed in the low-risk population, the vast majority were surgically explanted. They had a very low rate, I don't know why, a very low rate of redo TAVR, and the outcomes were pristine. So I'm wondering if TAVR explant, even with a higher profile prosthesis in healthier patients, is going to lead to better outcomes than what we've seen so far in the literature.
Yeah, I completely agree. The data that we have now are TAVIs that we put in like 5 or 10 years ago, and those were intermediate and high-risk patients. So I think it could be a completely different outcomes if we consider TAVI that were placed for low-risk young patients.
And are there any new techniques that are coming along for that? I know we talked recently with Keith Allen about surplus, just excising the leaflets and putting a valve within the existing frame. Any thoughts on that, or do you generally explant the valve if you can?
Yeah, for the explant, I tell surgeons, this is my tip, is to release the radial force. You got to find some way to release the radial force. So for the balloon expandable valves, you're going to have to deform the valve. There's multiple ways to do that. I try to turn it into a C and get the radial force off. You can't just go in there and just pull it as hard as you can. That will damage the aortic annulus. For the self-expanding valves, it is nitinol, so it's always going to be pushing outwards. For those cases, I get rid of the radial force by trying to resheath the valve, so trying to put it into something as crude as pump tubing or chest tube. You can get the valve back inside a smaller diameter device and thereby get it out safely without damaging surrounding tissue.
Yeah, and I think there was recently a paper from in Annals of Thoracic Surgery or from Dr. Koneko from St. Louis covering different techniques for TAVR explant. So there may be a lot more that you guys are certainly seeing a lot more, and hopefully the outcomes are going to improve a lot as time passes.
Well, I'm really interested in the TAV-in-TAV option, and I really don't know what is the best second TAVI to put in the first TAVI, and I think this could be a good option for patients to stretch out the lifetime of their aortic valves. So, I mean, if you consider a patient at 50 years old, if they do get a TAVI at the first one, we're hoping to get 10 to 15 years. Now they're 65. If they're able to get a good TAVI-in-TAV, boy, they're out to 80 years plus. It could be a good solution for some patients.
Yeah, I definitely think you're right. I think the challenge for TAV-in-TAV right now is that the data that we have is really not great quality. I mean, we have some limited benchtop data, including explant data for SAPIEN in failed evolutes out of Vancouver. But, I think there's a registry, I'm sure you know, starting in the US, there's a European registry, but they're very limited. I mean, the European registry is going to be 150 patients total, covering 4 different valves and potentially 16 valve combinations. So I think the thing that I struggle with is that if you put a valve in somebody young and you tell them, hey, in 10, 15 years you're going to have an option for TAV-in-TAV, I think you better be damn sure that that's possible. Similarly, if it's going to be an explant, that it's going to be a doable explant and not a bloody mess.
The other thing to consider, Andrei, is some more commercially available devices to counteract coronary obstruction. So when you do a valve-in-valve, whether it's TAVI in a SAVR or a TAVI in a previous TAVI, we're able to overcome coronary obstruction with some pretty novel techniques. The one that has caught my eye recently is the unicorn procedure. The reason is because there are some commercially available devices that are coming out now that are designed to do that unicorn procedure. And I think I understand the procedure correctly. Andrei, have you done those procedures before?
Yeah, we've done them. I think, I was talking to Toby Rogers recently, who's the person who taught me how to do basilica, about this. And I think we've done the unicorn. I don't think it's a perfect procedure. I don't think the basilica is perfect. I think basilica has some advantages. It is a little bit more laborious. I think the telltale that's coming out commercially now and the shortcut all have their own limitations. Time will tell. And I think the thing that makes me nervous again is telling people, you know, in 10 years from now there's going to be an option to remove the leaflets, and that may not be here. You know, I was at EuroPCR a month ago, and they have a percutaneous way to just cut the leaflets out and get rid of them, which looks great on the benchtop, but I would like a series of 100 cases before I commit the patients to that. So.
Yeah, I haven't seen the one that it can actually excise the leaflet. It sounds pretty cool. The way I understand a unicorn procedure, it is simply piercing the leaflet without cutting it, which makes sense, and then you can dilate that hole and then put the device in that hole and push the native leaflet out of the way. So I think it sounds a little bit simpler than a basilica procedure. We're looking forward to that to being a commercially available option in the future.
Yeah, I mean it is intuitive. It's a nice procedure. I think the two areas where we've had concerns, and we're contributing our cases to a registry with Emory. One is there is a concern that when the leaflet rupture, you can have an asymmetric rupture, which can result in too much leaflet going in one direction and potentially occluding the vessel. The other concern is that if the leaflet doesn't rupture with initial balloon inflation, you may encounter very high push forces when you're trying to introduce the valve. So both of those are concerns, and I think, as you said, you know, if we have a commercially available technique off the shelf that deals with these concerns, I think it's going to be a much better world for everybody. But, you know, kind of to wrap up, I think you said something earlier, which is something that's very intriguing to me, because we do the same thing that you appear to be doing, which is we're getting everybody who needs an aortic valve through the valve clinic. And we tell patients that we don't run a TAVR clinic, we run a valve clinic. You come to the valve clinic, you meet cardiology, you meet surgery, and in the end, we're trying to lead you towards the best solution for you. We're trying not to get patients to the clinic who know already what they're going to have, because I think the valve clinic concept is so much better than just a clinic where you have to come and get your stamp to get your TAVR put in.
Yeah, I think so. I think shared decision making is very important in 2025. It definitely takes more work, Andrei. I find we're spending a lot more time with the patient explaining all of the treatment options, and this goes from TAVI all the way to Ross, minimally invasive versus full sternotomy, not to mention mechanical versus biologic valve. We often spend almost an hour with one physician, and there's multiple physicians talking to the patient. And today's patient is an educated patient. They come to clinic already well-versed and come with clarifying questions about the options. They really want to seek the truth, and we can help our patients make the right decision based on their patient preference.
So to finish this on a controversial note, lots of kind of discussion about single operator TAVI. What's your thoughts about that? And I can tell you afterwards what my thoughts are.
Well, it certainly will free up the other proceduralists to do procedures elsewhere. So in terms of efficiency, a single operator for TAVI, I think, is the way to go. I just hope it doesn't lead to detrimental effects on the valve team, because right now, surgeon and cardiologist sees the patients pre-op, they do the procedure together, post-operative they manage any complications, which are rare, that come up. So each doctor has vested interest in how the patient does. That's why the valve team works so well. But we can't argue with efficiency, and it is going to be a consideration in the future.
Yeah, I agree with you. I think my main concern with single operator TAVI is that you risk losing the valve team, and in certain countries where they've had this for a while, they the people who are not involved in the procedure are not as incentivized to participate, and they're trying. Everybody is following their own interests, and I think it subtracts from the strength of the valve team and from putting both options on the table for the patient and letting the patient decide. Yeah, thank you so much. I think it was great. I think everybody who will listen in will have benefited tremendously from this. I am, so excited to have done this, and I'm sure we'll cross paths again. And if you ever have anything else that you want to discuss on Murmur MD, we'd love to have you. And we always love to have more surgeons and cardiologists on the app, because it makes the app better, and I think it's a great forum to exchange ideas.
Well, thank you very much, Andrei. I certainly had a great time on Murmur MD. Hope to share some more information in the near future.
Thank you. Really appreciate it.